Now we will briefly discuss in the last section, that is the terminal phalanx fractures. We will be going through different entities which are involved with the terminal phalanx fractures, especially the tuft and the mallet finger injury. We'll be going through the fracture of the terminal shaft as well as the jersey finger, which is associated with avulsion of the resulting in the either flexor tendon injury or in the mallet injury finger, which is resulting of the extensor tendon injuries as well. The fractures of the tuft. Usually, this is a very common injury presentation of children. They get caught, their hand may have been stuck by a hammer, or it gets caught in the door, or the bone shattered. With the catching of the hand in the door is very common, and especially this kind of an injury happens, and as you can appreciate, it's an open injury with then probably near belt avulsion as well, and you can appreciate the tendon of the extensor tendon is very much visible. As with the general rules, the first and foremost is examination under sterile conditions and washing the wound with copious quantities of normal saline, so that the any kind of it's fragmentation, any kind of necrotic material or any kind of a debris which is present must be removed, and so that later on no sort of infection can occur, because pulp infection is highly unstable, because it's quickly there's a pulp infection or pulp space edema. What happens is actually it's a confined space, and it quickly leads to vascular occlusion and eventually forming of a necrosis. So there is usually sometimes the loss of distal phalanx as well. In this, the fracture is not of the far most important, because there are other soft tissue structures which are far more important than the distal phalanx. Treatment is focused on controlling the swelling, regaining movement, and painful hematoma beneath the nail beds need to be drained. Sometimes in these cases you have to examine the nail bed as well. If it's damaged, you need to repair the nail bed as well properly, so that later on there is no extra nail growth which can create more problems or painful. It could be painful for the patient. Now coming to the mallet finger injury. Mallet finger injury, if you see, this is the finger, this is the proximal phalanx, this is the middle phalanx, and this is the distal phalanx. The extensor tendon actually come and attach on the dorsal side of the base of the distal phalanx. If this injury happens and gets avulsed, now the flexor digitorum profundus, which attaches at the base of the distal phalanx, this will keep the distal phalanx in the flexed position, and this is called as the mallet finger. This could be due to simple the rupture. This could be a soft tissue injury, or could be a cut which is resulting in rupture of extensor tendon of the most distal part of the extensor tendon, or this could be avulsion as well due to trauma. For example, this distal phalanx was held in a hyperflexion injury in which a lot of force was actually applied, and therefore there was avulsion of the extensor tendon, which could be due to a small flake of bone from the base of the terminal phalanx may get avulsed, or simply with the joint line unaffected. Now this is, as you can appreciate over here, the only tendon has avulsed. Now when this tendon avulses, this small fragment can also be taken along with the tendon as well. Other is actually the third type is avulsion, which is associated with a large dorsal bone fragment, and rarely the subluxation of distal interphalangeal joint occurs. Now they have three types of injuries. One is a purely soft tissue injury in which there is only extensor tendon injury. The other is an avulsion with either a very small piece or only avulsion injury of the extensor tendon. The third is actually avulsion injury with a very large piece of a bone attached to the tendon, and there can be subluxed distal interphalangeal joint as well. Now the treatment depends upon what type of injury it is. Distal interphalangeal joint can be immobilized in slight hyperextension. Why it is given in hyperextension? Show that extensor tendon is injured. It can recover over time. In 3 to 4 weeks time, the fibrosis of the tendon occurs, and actually it results in the healing of the tendon. If the tendinous avulsions, usually the tendinous avulsions occur painlessly. Splint can be kept initially for 8 weeks and then only for night or 12 hours for next 4 weeks. By the 12 weeks time, usually the fibrosis has been completed and the healing process of the tendon is complete, and later on the flexion and extension at the distal interphalangeal joint is very much possible. Now if it is associated with bony avulsion, now that depends what is the bony piece size is actually. If it's very small size, we can continue with still this treated estimate for 6 weeks. And why 6 weeks and why in 8 weeks when it's only tendinous avulsion? Because Tendon to bone union takes more time, but as it has this bony avulsion is there, which is, even if it's a small piece, bone to bone union is very much possible in 4 to 5 weeks. So for that case, the treatment splint can be only kept for 6 weeks initially, and operative treatment is usually avoided. But if it's a very large piece, we may have to go for a surgery in form of a small screw or a K-wires, which can be applied so that the bone to bone union happens in 6 to 8 weeks for most of the time. Now coming to the complications. What could go wrong with the complications, especially with the injury of the extensor tendon? The most common is the non-union, that is the tendon, bone tendon interface actually remains non-union, tendon has actually not healed properly, or the small piece which is avulsed actually remains, does not heal and remains in non-union actually. Other is persistent drop. Why? Because this means the tendon is actually, the tendon got avulsed and the tendon is retracted, so, and there's a large gap, and which therefore the tendon cannot function as normally and extend the distal interphalangeal joint, leading to persistent drop. Or there could be swan neck deformity as well. Due to attrition changes in the tendon, there could be tendinous injury at the proximal or at the middle at the base of the middle phalanx. This results in hyperextension at the middle phalanx, and actually flexion at the distal interphalangeal joint with the flexion at the proximal phalanx, leading to a classical called as swan neck deformity. Now, if it is a terminal shaft is fractured, as you can appreciate it over here, the distal phalanx shaft is fractured. If it's undisplaced, you don't need any treatment apart from analgesia, or even a buddy splint or trapezius splint can be done, but it's usually not even required. But the important point is, usually if it's associated with nail bed injuries, we need to be very careful of the nail bed injuries. At this stage, if it's only involving the distal phalanx, the bone is not the priority. The priority is the soft tissue structures. That's extensor tendon, the flexor tendon, and the nail bed, which is actually over there present. And if it's angulated, we can closely reduce it and can be held with either a K-wire or a simple through the pulp, or we can apply go for 2 K-wires and then apply the buddy strap so that the fracture is retained in its or immobilized in its position. Now the important point, as I told you, with the distal phalanx fracture is not the bone, it's the extensor tendon, it's the flexor tendon, the nail bed. Now coming to avulsion of the flexor tendon. If this occurs, flexor digitorum profundus is actually attached over the base of the distal phalanx, and extensor tendon is actually attached with the distal slip is attached at the base of the, on the extensor side of the distal phalanx. So if this is lost, the extensor tendon would cause this distal phalanx into hyperextension, and this actually results into sudden hyperextension of the distal joint, in which the flex FDP can get torn and leading to a Ruger Jesse's finger, or in which there is hyperextension of the distal phalanx, which is the ring finger is the most commonly affected joint, and it is due to the flexor digitorum profundus tendon, which may get avulsed as it is attached to the base of the distal phalanx of the on the volar side. If the bone fragment is small, it can recoil. The important problem over here is actually not the bony fracture. The problem is the proximal part of the FDP, because FDPs and FDS are very notorious in recoiling. Although this is a zone 1 injury of the flexor tendon and it relatively stable and recoils very less, but if it's usually zone 2 and up below, then it can be very damaging, because these flexor tendons can recoil very much and they may have to be traced back so that they can be brought back into this place and can be sutured. So therefore, sometimes the retraction occurs so much that is a very large gap and it cannot be covered in one go. Therefore, we have to go for 2-stage repair. In the first stage, this is actually it's splinted for a few days, and then we can later on suture the 2 ends together in form, or we can apply a tendon graft. Now coming to the physeal fractures. In children, although this is very common, especially in the case of the distal, called as Seymour fracture. Seymour fracture by name is actually the distal physeal fractures with the distal phalanx. In especially, it is a displaced fracture of the distal physis in the distal phalanx of the children. and nail may be dislocated from the fold. In this, actually the problem is not with the bone as is Pfizer injury, but the main problem is with the nail bed. A nail bed has to be examined properly, and if it is nail bed has been avulsed and the germinal matrix may be trapped in the fracture, and injury can be easily overlooked. So we have to take out this nail and we have to go for nail bed repair properly. Rather than focusing on the bone, we have to focus on the nail mostly, and then nail must be cleaned and replaced into the bed so that the this nail bed abnormalities do not occur later on, leading to painful fingers. We have discussed in this section briefly with the fractures with the distal phalanx. Distal phalanx, the first and most priority is not the bone. We have to usually forget the bone. If it's simply undisplaced, we can simply do the conservative treatment. Even if it's displaced, this can be reduced back and a K-wire or screw can be placed through the pulp. Usually the most important with this is actually formation of mallet finger, in which the distal slip of the extensor tendon actually gets avulsed, leading to the permanent flexion of the distal phalanx, which I'm calling the mallet finger, which has to be treated because there is avulsion, which could be simply the tendon avulsion or could be the bony avulsion as well, and it has to be treated in hyperextension splint for at least 6 to 8 weeks. Other injury which is very common with the distal phalanx is actually called as the rugger finger, in which this is what happens is the FDP, which is attached at the base of the distal phalanx on the polar side, if it gets injured due to any cut or due to hyperextension injury, this will cause the hyperextension at the distal phalanx, and if not repaired properly, this can lead to chronic injury and rugger injury. Sometimes this FTP can be repaired in one go, but if it has retracted too much, we can go for two-stage repair of the FTP as well. Thank you very much. Keep watching sqadia.com.